Hello, Rukia, are you there?
Hello. Yes, sir. We can start,
Yeah.
sir. Hello.
We can start?
Yeah.
So, good evening, eminent faculties and dear doctors. Today, we are gathered here to attend our GU Live meeting, which is Pfizer Oncology's initiative for urothelial cancer treatment management. So, today, our topic for GU Live meeting is first line maintenance treatment of metastatic urothelial carcinoma from clinical trials to clinical practice. So, today, we are eminent speakers in our faculty list. So, I will introduce the faculties first. Then I will hand over the session to Shyam Agrawal sir. So I will start with the disclaimer that this meeting is exclusively for invitees only. If you have not been invited to this meeting by Pfizer, we request you to kindly log off. The meeting initiator reserves the rights to block unintended recipients. Video, audio recording of this WebEx meetings is strictly prohibited. So this is our today's agenda. First line maintenance in the treatment of metastatic urothelial carcinoma from clinical trials to clinical practice. The session is moderated by Dr. Shyam Agrawal sir with esteemed expert discussion for panelists. We have Dr. Bharat Bhosle sir, Dr. Kaushal Patel sir, and Dr. Ajay Kumar Singh sir. So Shyam Agrawal sir is a director and head of medical oncology department at Navodaya Cancer Hospital and Research Center at Bhopal. Sir has done his DM training from Cancer Institute, Chennai. Sir has more than 30 years of experience in the treatment of different tumor types. Sir is a principal investigator in 3 PMS studies. Sir is also chairman and secretary of many state-level organizations like NETCON, ISO, ISMPO, and advisor of ICMR for Bhopal Guest Victim Patient Committee. Sir has also attended many international and national conferences as faculty, and sir is also lifetime member of ESCO, ESMO, ICON, ISCCM, and Mumbai Hematology Group. Then in panel, we have Dr. Bharat Bhosle sir. Bharat Bhosle sir is a senior medical oncologist attached to Bombay Hospital, Jaslok Hospital, HN Reliance Hospital in Mumbai. Sir's academic achievements start with first prize for designing trial of adjuvant chemotherapy in node positive hormone receptor positive breast cancer, ICON Nagpur 2011. And sir is also first prize winner in medical oncology quiz COPE Chennai 2012. Sir has also attended various international, national, and state level conferences over last 10 years and has many publications in national and international journals. Sir is also selected for University in Zurich for ESO CAS in lung cancer program 2020-21. Then we have in our list Dr. Kaushal Patel sir. Sir is a senior consultant medical oncologist. Sir is also practicing at Elite Hemato-Onco Care Center and 6 other hospitals across Surat. Sir has been awarded as Best Oncologist in South Gujarat in 2018, 20, and 21 consecutively by Times of India Group. Sir has also published a number of clinical trials. Then last but not the least, we have Ajay Kumar Singh sir. Sir is assistant professor in medical oncology department in Tata Memorial Hospital, Mumbai, with more than 5 years of experience in clinical oncology. Sir's achievement includes gold medal in MBBS, received merit award for annual American Society of Clinical Oncology meeting 2022 in poster discussion Chicago in 2022. Sir is also awarded for Conquer Cancer Philip Francis Mulvey, a second endowed merit award supported by Thesis Marin Mulvey, MD, FASCO. Sir has more than 10 plus publication in international journals and participated in more than 20 national and international meetings as speaker, moderator, faculty, and panelist. So, sir, over to you, sir. Shyam, sir.
Yeah.
Yeah.
So thank you much, Dr. Nishant, Mr. Nishant. Actually, uh, uh, all the details of the topic you have already narrated. So I am not going to the basic topics detail, but definitely we have excited and practice changing study, that is Javelin Bladder 100, and what we are going to discuss with all our esteemed panelists, Dr. Bharat, Dr. Kaushal, and Dr. Ajay. So, as told by Nishant, I'm a medical oncologist working in Bhopal Navodaya Cancer Hospital, and just to extend that thing, like we cater all kinds of patient, cashless as well as those paid patients. So we have empanelments with all other organizations, and what is the significance of this is that we can get the patients who can be sponsored by Vivencio or Velumab. So I would like to inquire about the atmosphere of the hospitals. My panelists are there. Dr. Bharat, can you tell me what is the atmosphere like? You do practice in 2-3 major hospitals. So how these patients are being catered? Like they come directly to you for the these immunotherapies, or like you have to arrange them, or how many patients those can afford the high cost medicine through this pocket? And I will ask Dr. Ajay also and Dr. Kaushal also the same thing.
Yeah, so broadly, if you ask me for immunotherapy across all the tumor, because of the cost, not only the high cost therapies, people trouble to get to have a big trouble. Financial toxicity is a big challenge.
That's
hardly
true.
hard.
Yeah.
Yes,
Yeah.
yes. So 10 to 10, maximum 10% you say, but not up to 10% also can't afford to have therapies.
Yeah.
It's not basically 6 cycles, it's at least a 1 year. So you have to tell them actually what is the true fact, which
Minimum
is not
1
less
year.
than 35 lakhs per year. So it's very difficult.
Yeah. So until the patient is sponsored by some organizations, becomes very difficult. But how many patients you must have treated till with this molecule, Velumab?
So we'll just know, as you asked about the cost constraint, we know that some of these molecules are very good. Now for urothelial cancer, what happens is, like across the GU tumor, most of these patients end up in initial treatment with the surgeons, as you know, urologists, because we start from kidney, there were a lot of TKIs. So hardly patient we used to cater those patients until the patient lands up into trouble. So with the immunotherapy, what actually has started, at least surgeons started sending patient. If you talk about bladder, now surgeon also realize that to handle cisplatin toxicity is also not easy. And then the patients have other options of not doing PDL1 and then go for one of the therapies. I think now surgeons are also now freely discussing these cases with us. And there are a couple of cases which surgeons have started sharing upfront. Taking for the new agents also, they are sending, they are now discussing these cases, which is a good thing. Because pembrolizumab has come up into non-invasive bladder cancer also. But at the end, the usage is very limited. At the end of the 4 cycles, you have good response. And out of 100, you say, still it is the single-digit number, not more than that.
Definitely. And more challenge come when, Dr. Bharat, when we say that this molecule is only for the maintenance. Like that becomes more, counseling sort of, we have to sue the patient that you have done initial chemotherapy, patient is a stable disease. Now we are going for the maintenance. So for spending, maintenance, so much of amount, most of the patient, the 2 of my patients, they were just shaky and they could not get it. So that is also a challenge which I could find. Dr. Kaushal, Dr. Ajay, what is your hospital atmosphere and environment like? How you are getting these patients? I think Dr. Kaushal is.
Good evening, sir. Myself, Dr.
Ajay.
Yes, sir. Good evening, everyone. Good evening, Sam, sir. Myself, Dr. Ajay. So right now, sir, I'm working in TMS, and for last 2 years, I'm seeing GU group of tumors.
Okay.
So till now, in last 2 years, I'm able to keep 3 patients on Avelumab maintenance, despite there are large number of patients who are ideal candidate to start with Avelumab. But again, the group of patients who are coming to Tata are not as much as affordable like Bharat sir.
All over India, same thing.
Yes, sir. So at least in our maybe around 5%, 6% patients, maybe we are able to put them on Avelumab maintenance because of the financial constraint.
Okay. So how long you plan to, at least in the first go, you plan for 1 year, 2 year, or maybe,
So we are, sir, going as per protocol only 1 year, but at least not 1 year also, though, at least we are counseling for minimum 6 months. 6 months.
6 months. Okay.
But ideally, we are trying to push them for till 1 year.
Yeah, definitely. That is the minimum benefit we can get. Dr. Kaushal, how about you?
Yeah, the same thing actually, which is I think common all over the India. There is nothing new. It's a very wonderful drugs which can be used in maintenance therapy, because after the chemotherapy, definite progression of the disease will be occur within short period of the time. But only constant came is the cost. I have used in a couple of the patient. Tolerance is good. I would like to give it for 1 year if the patient can afford. Otherwise, there is no any major issues with the drug. And it's a good options as a maintenance therapy.
Yeah. So all our panelists are agreed that definitely this is a good molecule, wonderful molecule. The only thing we need to, see the, financial toxicity, as Dr. Bharat said. So can I have first slide, please? So we all know that the backbone of the chemotherapy in bladder cancer or metastatic bladder cancer is platinum. And then we have GemCis, the preferred regimen, for which we have overall survival is around 14 months and the response rate is around 15%. Can we have first slide? And then if patient is cisplatin ineligible, we go for carboplatin. That is little inferior OS and the response rate compared to cisplatin. And then only minority of the...
Hello, sir. Yeah. Nishant, sorry to interrupt, sir. Sir, you have to share the slides, sir.
Ajay, you cannot share. Okay.
Yeah, sir. Sir, the slides are only with you.
Okay. Actually, these slides, the other set. Anyway, let me check this. So, can you see my screen? Are you able to see my screen?
No, sir.
No. Okay, then how to share that?
So just share. Click on share screen option.
Just a second. So there is share more option.
Besides checks, there's green color
where
button.
it is located in the
below your
share
screen,
content. So I will start with screen sharing. So start broadcast 3, 2, 1.
Yes, sir. We can see your screen.
Yes.
9, 10. So, like only minority of the patients, say around 1/3 of the patients, they can receive the second line treatment. So that's why the first line treatment is very, very important, and we have to, bang on it. We have to, this the unmet need to improve the survival scores and the frontline therapy, as we are going to do the. So why it is not showing now? You are sharing screen. I'll come here. Now it is okay?
Yes, sir. Yes.
Yeah, sir. Now.
Okay. So this we have already discussed. So this is what I was telling that only 1/3 of the patients they could receive the subsequent line of therapy. So we have to bang on the first line therapy to the best available, because otherwise the survival and the response rate goes very low. So now, Dr. Bharat, what percentage of patients you see in each segment, like eligible, non-eligible? We'll first talk of patient ineligible. What percent of patient you have those come to, like percentage or the number you found that this is ineligible to the platinum compound, whether cisplatin or carboplatin?
So if you look at no cisplatin eligibility, unless and until the patients are seen in the neoadjuvant setting where there is an opportunity to offer this drug, once you do the surgery, what happens if there are tumors sitting at the ureteric tumors? Few of the patients end up in getting the nephrectomy also. No, I'm not talking about all patients. So giving cisplatin to them becomes difficult with single kidney. These patients are 60 plus most of the time. And if you add audiometry also, then it's a big challenge. Yesterday only I saw one of the patient who was 62 fit guy. But then if you look at the cardiac eligibility and the peripheral neuropathy and audiometry, he has slight hearing impairment. He has started neuropathy because he was diabetic, though it is well controlled. Now, if I apply all the criteria, sometimes we end up in not giving cisplatin. So, how to know how strict we have to be for all these criteria? Yes, one has to be very careful with the heart MIH classification. Do 2D codes whenever there is a question. You can do the stress test also. But yes, one has to explain all these side effects in spite of not showing these grade 1 neuropathy or hearing loss. Patient may end up in getting the cisplatin toxicity. So it is better to tell them that you can have a good effect, but you can have the side effects. At the cost of side effects, you are ready to get the survival advantage. That needs to be discussed.
Yeah, definitely. And there is a very thin line between the carbo and cisplatin eligibility. So when you think that patient is cisplatin ineligible but carbo eligible, like you do certain test or some kind of GFR and
So for carboplatin ineligibility, I hardly come across, because we have we had to give carboplatin for most of the patients with those who are CRF patients. Then there is no option of thinking about cisplatin. But then if knowing the fact that these patients do respond to carboplatin also, but obviously in the adjuvant or neoadjuvant setting, it is the cisplatin only, which is superior to the carboplatin. But when we deal with the metastatic setting, most of the time I prefer carboplatin. Carboplatin ineligibility is a very difficult definition. I haven't come across unless until somebody has a severe hypersensitivity. That is one of the criteria, I guess.
Okay, but Dr. Ajay, how do you decide whether you want to give cisplatin or carboplatin to a patient? Dr. Ajay is muted.
So, sir, from at our place, generally we try to push the patient to go for cisplatin only because of the data and the response rate. And but maybe around 15-20% we are finding patients who are not eligible for cisplatin. Because of the various defined parameter like creatinine clearance and this audiometry finding and cardiac comorbidity. There we start carboplatin. So till now, sir, I am also not find any patient ineligible for carboplatin, except who are having very poor PS. They are not fit for any form of chemotherapy. And another is that carboplatin hypersensitivity. Otherwise, our preference is, even if borderline patients who are having creatinine clearance between 50-60, we try to give divided doses cisplatin. But as sir mentioned, we need to balance multiple things like comorbidity, patients' fitness, everything. So around maybe one fourth to maybe 1/5 of patients are not eligible for cisplatin.
Okay. Dr. Kaushal, how you decide whether patient is cisplatin ineligible going to carbo or ineligible for both?
Actually, in first line metastatic urothelial malignancy, my approximately 50 to 60% patients, they are the cisplatin eligible.
Okay.
If we divide between cisplatin eligible and carboplatin eligible, then sometimes the patient performance condition is good, but the creatinine is very high. So at that moment, we can give the carboplatin by calculating the AUC, and then we can give the platin instead of the omitting the platin. So this is the minor difference between cisplatin and carboplatin ineligible. But most importantly, we can say that approximately 60% patients, they are the eligible for the platin anyhow, and 40% of the patients, they are the ineligible in our clinical practice.
Okay. So my question to all of you is, how you calculate GFR? It is by the calculator given in the app, or you really see the 24 hours urine and then calculate GFR? Dr. Bharat.
Yeah, Dr. Kaushal here, sir.
In
this era, because it's a chemotherapy is very repeated process.
Yeah.
Very difficult for us to collect the 24-hour urine collection and then get the GFR. Routinely, we are calculating the GFR according to the clearance from the applications. Frankly speaking, sir.
Yeah, definitely. Maybe Tata having the real protocol, they are also not doing this. Ajay, you are not doing 24 hours urine collection, because I also see the era is gone to collect everything for 24 hours. In our olden days, when we were in CI, we used to do this, and my director was very particular about this. Probably that time we did not have the app or the calculator in the Google. So GFR, what like I read now, that if patient has got GFR is beyond 50, then cisplatin eligible. 30 to 50 GFR is cisplatin ineligible but carbo eligible, and less than 30 is ineligible both. Apart from other factors, as Dr. Bharat and all said, we have so many other factors like performance state, neuropathy, and heart failures and performance state. So, like Dr. Bharat told about audiometry, do you routinely do audiometry, or it is just a patient's hearing kind of history will do?
Yeah, I have started doing the audiometry.
Okay.
Because you see those, even though patient says I am okay with hearing, sometimes there are no high frequency losses which are severe, and you give first, and then patient starts getting tinnitus and hearing impairment. This I have faced in germ cell tumors recently, young patient, not old patient.
Yes.
So I make sure that I explain everything to the patient. Sometimes you don't have a problem on the audiometry, but still patient have problem, gets problem. So it's better to explain them. Sometimes we end up in getting mild impairment. So tell them that no, this is a very important drug. We have this mild impairment, grade 1, less than grade 2. Still, no, you can use cisplatin. So you have to talk to the ENT person. What is the grade of this thing? So this is very difficult to keep the grades always in mind, because this is not
definitely.
So once we understand that, lower grades I do use cisplatin.
Definitely.
Severe grades I don't use.
Yeah, and I think it is evidence based. No, so if patient goes to the consumer, that this doctor has made me
absolutely. So I'm telling you, yesterday only, I was talking to a Tata TCS HR head. Her father had this, and he's referred to me for neoadjuvant. And she was very categorical. She has already studied about robotic surgery versus open surgery, what is the survival advantage and everything. So I wrote everything. The patient had grade 1 neuropathy, I documented. I said, this is the survival advantage. This grade 1 can become grade 2. The audiometry is showing mild sensory impairment. I told them, in spite of that, he may or may not get. So she clearly told me, it's good that you explained to it, and one should know about all these side effects. So there are educated patients. We can't take them for granted.
Yeah. And rather, Bharat, I came across a patient who was singer, and he used to have feedback through the ear, the notes of all. So he started hearing those. I cannot sing because I did not find where is the sa.
Yes.
The professional thing, we have to be extra vigilant about that.
No, this is different era. And one has to tell all the side effects. Let's better know patient search Google. Sometimes we say patient Google ka search karta hai. Better let them search and come back with the question and answer all the questions before starting anything.
they solve our problem also. If they are aware, then we definitely send them to ENT specialist, go for the audiometry. That's true.
Yeah,
So,
long term side effect avoid करना है हमारे लिए long term side effect.
हाँ, वो हमारा side effect avoid करना. That's true. That's great. So now we have already discussed that what is the OS when you give only chemotherapy. So OS is around 14 months and response rate we have said it is around 50%. So this is what they have said ki even though 75 to 80% of the patient achieve disease control, but out of those 25 to 55% of they do not receive second line therapy because the patient progresses within 9 months and the survival is very poor. So we need to improve this survival data by filling the gap of the unmet need. So here this trial has done. So Dr. Ajay, in an unresectable locally advanced, you have given chemotherapy, and then which policy or the the option you will take, whether you will wait and watch, continue maintenance or switch maintenance. What is your take on this?
So sir, in this metastatic where local therapy is not feasible, so generally we are giving 6 cycles of chemotherapy, platinum based, and followed by, if possible, we are keeping patients on avelumab maintenance, which is not practically feasible in our population. So most of the time after 6 cycles, most of the patients are on observation only.
Okay. Dr. Kaushal, how about that option? Like which one you choose out of these three?
Sir, continuous maintenance would be the better options. Because if we give the continuous treatments, then it will give the better control of the disease rather than giving the wait and watch and then switch maintenance therapy. If the patient they can afford, then we can definitely go with the continuous maintenance therapy.
Okay. So here, what is the evidence we see for the each option? For the wait and watch, this first line disease progression, you initiate the second line. This is what the data says. The 50 to 80% of patients achieve disease control with first line platinum based. However, OS is limited because of the chemotherapy resistance. And then the median OS, as we discussed, it is around 14 to 15 months through cisplatin based, or if you have given carboplatin, it is 13 to 14 months. So definitely wait and watch will not be an option. Now this question is coming before we go for the other options. Is there is a role of IO in the first line, Dr. Bharat?
Yes. Unless until the patient is ineligible for chemotherapy at all.
Okay.
That you can think of using immunotherapy, but nowadays we see patients are fit enough to take this chemotherapy, and we know that once we very limited options. So better, if possible, cisplatin, gemcitabine, get a disease-free interval of at least 1 year. Re-challenge with platinum, because other drugs like paclitaxel or other drugs, hardly they have a PFS advantage. So my always attempt is to use the cytotoxic chemotherapy upfront. Once that fails, you have always the option of, or if they respond, always the option of maintenance, which is switch maintenance to immunotherapy, and then subsequently, obviously, if the patient has not used immunotherapy in the first line and there is a observation period and the patient recur. Based on the available data, we have done PD-L1, you have option of using Keytruda. If it is not done, I have also used nivolumab, avelumab. So immunotherapy, yes, it works, but again, compliance is a problem. Those major the patient don't come back. Like 52% of the patients end up in not coming back to the clinic. So especially in the tier city. So the usage should be as a switch maintenance wherever possible. In compliant patient, definitely can use it as a second line. First line, so far I haven't used, but if the patient insists I don't want to use chemotherapy and the PD-L1 score is very high, I would like to discuss the option of using immunotherapy.
Okay. So like either you have used the chemo or like patient is ineligible and you are planning to give IO, would you like to do PDL1 testing, or you without doing PDL1 you will start IO?
So it depends upon which molecule we are using. Second thing is in which phase you are
It
using.
is up to you. You use
Yeah,
whatever you want.
Yeah. So I'm just talking about the upfront. If I upfront, because I have used it upfront. I have personally used it upfront in a patient who had a PDL1 score of 30%. And he had a phenomenal response. Very good. I would not name the drug because it's not right to know name the drug.
We are not into
Patient,
that's why we are
actually
saying
the patient,
only.
I'll tell you the ureteric tumor and very high 30%, not very high, 30% PDL1. And I have used and phenomenal excellent response. Still patient is in CR after 3 years, but the now patient developed arthritis. I suspected it's immunotherapy related. Everything was ruled out, and now after starting the steroids, the patient's arthritis settled. Low dose steroids. It's immune-related side effects. So I have seen excellent responses. Having to know that, so you definitely can use PDL1 as a marker for those FDA approved kit for those drugs.
Okay. Dr. Ajay, what is the protocol at TMC? Like you plan to give IO because of ineligibility of the chemotherapy. You will do PDL1 or you will start straight to IO?
So, sir, so again, regarding deciding first line IO, so one is this upfront, everyone knows when patient is platinum ineligible, there are now proven data we can consider first line IO. And there are also a group of patients who are elderly, not fit for chemotherapy, where we think of BHC. So there also, sir, we give patients, patients, and we discuss with the relative. And if they agree, then we start immunotherapy. So for me, sir, personally, I don't like to do PDL1 scoring and with any of the molecule available. But for the if any educated patients are coming where I know in future they may create some issues. So for that purpose only I do PDL1. Otherwise, sir, for starting immunotherapy at any location, lung or I don't prefer to do PDL1 scoring.
Okay. Dr. Kaushal, how you do this? You do PDL1 in a patient with the chemo ineligible and you are planning to start IU? Are you hearing Dr. Kaushal? Anyway, so this is an area where definitely the patient who is PDL1 positive, they do better as compared to those PDL1 negative. And PDL1 negative, most of the time they go to best supportive care also. That is what the trial I'm going to. So here the study.
Hello.
Bharat.
Hello. So basically, there was an update of the FDA for first line because when I have taken a consent from the patient. So there was a discussion when they looked at the first line data of IO. Those patients did worst as compared to gemcitabine cisplatin. So wherever possible, one must use cytotoxic chemotherapy first. This was keynote trial, and your patient has to be cisplatin ineligible.
Yes,
and those patients should have a PDL1 expression at least of a 10. And if the patient is not eligible for any platinum, cisplatin as well as carboplatin. So carboplatin ineligibility, as I said, is very difficult because most of the patients are carboplatin eligible at least. So in those patients only the PDL1 status is not required. So if you are fulfilling, then only you are not supposed to use Keytruda and not for all the patients. That's why the first option is always chemotherapy.
That's what. So this is what you said, absolutely fine. But if you want to assess the response prior to giving IO, if it is PDL1 positive, they're not only the indicated the Pembro, but they are also responding much better as compared to those PDL1 negative. So that is what.
Yes, now, for avelumab.
This one. So continuous maintenance, there are 3 trials. MVGOR 1301, Note 3612, and Denob. In a continuous IO maintenance, there's no significant difference found in any of the 3 trials where they have used atezolizumab and Pembro with platinum or durvalumab with tramitinib. So basically, they're all negative trials. So the second option of continuous maintenance is absolutely the data is denying the continuation. And this is what the different graphs of these three trials we have shown to you. So this is there's no one, no trial is showing the survival or PFS benefit. So they're all negative. So now coming to the switch maintenance, that is what the Javelin Bladder 100 trials is showing. So that is the only phase 3 trial demonstrates significant OS as well as the PFS in the maintenance setting. So this another comparative trials were there where they've given chemotherapy and IO maintenance. Avelumab was used in Javelin 100 and Geo 14182 phase 2. They have used Pembro, and in the Pembro trial they have not found any significant benefit of the maintenance, but definitely there was significant benefit with the phase 3 trials of Javelin Bladder 100. So head-to-head trials were not there, but definitely there are different trials where Pembro failed in as maintenance and Avelumab showed the significant OS and PFS. So coming back to our all three trials, three options putting together, the switch maintenance is the only approach that has translated into maximum OS. Wait and watch has failed and continuous maintenance also failed. So this is what the summary of the different strategies of platinum eligible. And they have once you have given platinum combination with gem, then the patient relapses. Then there are different combinations were used, and nothing or no combination whether given IO or IO plus chemo or chemo alone or with placebo with best supportive care. Nothing showed, no trial showed OS PFS benefit except the Javelin 100, which showed the benefit of the OS and PFS. So this is what the now standard of care, that maintenance treatment in the first line, Avelumab offers an alternative option to the wait and watch, who are progression free after first line platinum based chemotherapy. And this is what the justification or the scientific rationale that the IO Avelumab works with the previous treatment. It prolongs the response and it maintains the quality of life also. And this is what the details of Javelin you must have gone through many times. It is a phase 3 randomized open label parallel arm when conducted in 370 locations, catering 700 patients. So we can assess the rarity of the disease. The 370 locations gave only 700 patients, so around 2 patients per location. Like very rare disease, and they were all locally advanced. And this is what the trial arms were there. So they have started induction chemotherapy in an unresectable, locally advanced or metastatic unresectable urinary biliary measurable stage 4. And then they've given gem or carbo cisplatin 4 to 6 cycles. So Ajay told that they give 6 cycles. Anybody give less than 6 cycles? Dr. Bharat or Dr. Kaushal, you stop at 4 or 5, or you continue to give 6 and then only you stop and give trial to give the Avelumab.
Sir, it depends upon 2 things, sir. One, the effect of the treatments. If the patient is responding to the line of the treatments, then we can go ahead with the 6 cycles. And second thing is it depends upon the tolerance also. If the patient is not tolerating the drugs, then we can have to stop it at the 4 cycles also.
Okay. Dr. Bharat, Dr. Ajay?
Yeah, I agree with Dr. Kaushal. It's based on the patient factors as well as the tumor factors. If the patient is fit, there is excellent response in the form of so why not to give 2 more cycles? Only problem becomes the creatinine clearance or toxicity of cisplatin is important, becomes important after 4th cycle.
Okay. Dr. Ajay?
I also agree, sir, with Dr. Bharat sir and Dr. Kaushal. So our means optimal approach to give, but we need to modify things according to how the patient is tolerating the drug and respond, how he is responding. And if sir, if I know the patient will then maybe I'll stop preferably at 4 cycle only.
Yeah, that's good. So after 4 cycles, we assess the toxicity and efficacy, and we take a call to stop or continue till 6. So now you have given all 6 cycles. And so how long you wait? That the treatment-free interval is around 4 to 10 weeks. So how long you wait for the radiological assessment? And when you call this, the patient have got stable disease, CRPR or stable. So 4 to 10 weeks is kind of a gray area, which I suppose we have to take a call to start avelumab. So Dr. Bharat, how much interval you take for your patient to start avelumab?
So usually we counsel the patient upfront only. If this is the plan of action, whether 4 cycles, 6 cycles, and there is a response, we have to go for maintenance.
Yeah.
So unless until there is a time window period patient wants for arrange the finances, it's better to start after 4 weeks. But yes, you can start from anywhere between 4 to 10 weeks.
Yeah.
What happens is sometimes the patient starts coming back with the tumor. Sometimes the responses are very short-lived. Better start earlier.
Yes.
If you want to start and the patient has money, why to wait?
Yeah. Dr. Ajay, how much?
Yes, I also agree with sir.
Yeah.
Maybe 4 weeks may be ideal. So at least I'm not wait beyond 8 weeks. So maybe within 4 to 8 weeks we try to start the avelumab if feasible for the patient.
Mm-hmm. And about you, Dr. Kaushal, you take 4+ weeks. How much time you take?
Yeah, as early as possible, it is better because it's a stage 4 disease and unresectable. So the disease progression can happen anytime, even after the stopping of the chemotherapy. So I would like to start it as early as possible when the patient is fit. 4 weeks is fair enough time where we can start the avelumab. Though we can get the response and result also even after the delayed starting also. But if everything is fair enough, then we can start at the 4 week.
Okay. So like Dr. Kaushal, you counsel the patient right from the beginning that we are going to give you with chemotherapy and then we'll start with maintenance, or after taking your call on induction chemotherapy response and then you counsel? What is the time of counseling?
No, sir, it's a day 1 counseling because if we want to start the avelumab after completion of the chemotherapy, then we need to explain the patients and relative regarding the plan of the action we are doing after the completion of the chemotherapy. And second thing, the cost is the major factor here while therapy. So it will be explained during the first consultation.
So many times patient will say they will take more time. We will arrange the finances. It will take 4 weeks or 10 weeks. So we can't hold it. So it is a patient call also. To if they are ready with the finances, then only we can start. So the financial assessment also. So day 1 before starting induction chemotherapy, if you are planning Javelin bladder 100 trial, then definitely you have to counsel the patient from the day 1 that we will, after 4 to 6 cycles, we'll give you avelumab that is costing this much and that much. That's great. So scientific rationale, we know how to, this is combining. Then baseline characteristic. The important thing, if we find out the gender, if as Bharat said, the more of the elderly patients, and only 1/3 patients were female, more were the male patients. They were visceral and non-visceral also around 50-50. And because the trial design was to take only 0 to 1 ECOG performance status, patient was given first line chemotherapy of cisplatin around 50%, carbo 42%, and 6% those patients were who started with cisplatin and then converted to carboplatin. So this is what the baseline characteristics, and these are the unprecedented OS benefits in the overall population. 14.3 versus 21.4 months. So the benefit is around 77.1 months, hazard ratio 0.69. That is about the OS, and the PFS was also improved around 8.8 months, hazard ratio 0.76. This is in the population of who are the PDL1 positive. So Javelin also has done PDL1 positivity. And in spite of having PD-L1 positivity, the response was much better. Those patients has PD-L1 positivity with the avelumab, and the hazard ratio 0.56 to 0.69. And it hardly matters first line treatment you have given, what kind of treatment you have given, but definitely all subsets of patients, whether they are, age 65 or less than 65, male or female, ECOG performance 0 to 1, whether they are Asian or other ethnic zones, Europe, North American, they almost, they have all, except I can see that Australia patients, they did not do better. So I don't know what happened. We have to check it from the investigator. So these are the benefit across, and this is overall population where the patient treated with avelumab plus best supportive care continue to achieve a longer median period compared to those treated with BSC alone. This is we all know it has all come into the NCCN guidelines, ESMO and UAE. This is what they're asking. Would like to perform PD-L1 testing before starting avelumab as maintenance. So for avelumab, it is not required to do PD-L1 because whether it is a PD-L1 positive or negative, patient responds very well. Now coming to the question, would your treatment approach be different if the patient has achieved either CR, PR or SD, stable disease? So Dr. Bharat, I will take if patient you have gone to CR, still give the avelumab, or you will give only for the PR or stable disease?
No, so basically the data is for all CR, PR and stable disease.
Yes.
Even though patient goes into CR, the problem of these patients is the maintenance of the CR. The duration of response is very short-lived with the chemotherapy, not with urothelial but other diseases also. So to maintain that CR, we have to have a consolidation, and as we know that most of these patients will not come back to the OPD or daycare. It's better to maintain that with whatever immunotherapy switch maintenance, because maintenance with the gemcitabine is difficult. Myelosuppression is a big problem. So you better go ahead with the switch maintenance.
Because most patients, they achieve CR, they will say, why you are treating so much costlier molecule? I'm fine. I have no disease. You have done PET scan. And then, so I came to this point, how the radiological assessment with the CT scan only, or you do PET
so
scan
that's what
only?
happened. That's what happened.
Yeah. Okay.
So it's basically what investigation you have done at baseline. Ideally, one should repeat that one only. Unless until you have an excellent radiologist who can give you the idea about the response in the form of necrosis. So as Dr. Kaushal rightly mentioned in the beginning, and I also mentioned that the counseling should happen at baseline only. Even though you are going to achieve CR, still you have to take this option of IO. Otherwise, as you said, patient will say no, there is a CR. Patient will disappear.
That is the problem. Okay, Dr. Kaushal, if your patient has PR and wants cystectomy, would you like to advise, or you will, because cystectomy say okay, my bladder will go, I know metastasis, so why to waste so much money, and better to remove the bladder? Any call for that?
I don't think so, sir. The cystectomy will help in this particular subset of the patient in form of the survival. So I do give two options in this particular subset on day one, either maintenance avelumab or base support. That's it.
Okay, great. Dr. Ajay, what you will do, patient is in PR, maybe no lymph nodes, no metastasis. Option, you given a tumor board, or your surgeon says better to remove this. How will you defend this?
Those are actually upfront only. When we are seeing the patients and where we are counseling, there only we should be very clear regarding our intent. Once palliative is always palliative, because we know irrespective of the CR, definitely it will going to come back.
Okay.
So it is our initial counseling matters, so that patient also should understand irrespective of CR, PR. They should follow the protocol what we are started.
So once palliative, always palliative. That's good. Okay. So this is what what we were discussing, whether patient has a complete response or partial response or stable disease. Avelumab did better, and then they give the irrespective of the response to chemotherapy, the graphs are separating. And PFS also, irrespective of the prior response, it is all separating. So avelumab is the choice, not the surgery. Can we consider avelumab irrespective of chemotherapy offered in first line? Dr. Bharat, can we consider avelumab irrespective of chemotherapy? You have given either cisplatin, gemcitabine, or Pacli, as you said.
Yes.
Okay.
Irrespective of the platinum agent, whatever you response, at least a stable disease, consider.
Okay. That's really coming into data also, that whatever first line you have used, whether cisplatin, carboplatin, or other chemo molecules, I think it is not into Javelin, but otherwise also the chemotherapy arm, whatever you've used, it is all benefited by giving avelumab in the first line, irrespective of the first line chemotherapy. So that we have already discussed how many cycles of chemotherapy we have already discussed, and overall survival is not affected by number of cycles. So as we discussed, whether 4, we see the toxicity and efficacy, we can stop after 4 or can give 6 cycles if patient is tolerating and responding well. And whatever you do, whether 4, 5 or 6 cycles, giving avelumab will not hamper the benefit of this. And this is about how soon you will like to start. This also we have discussed, 4 weeks, 6 weeks. So if a patient is prepared with the finances as early as possible, or whatever the call we take on the clinical grounds. But data also is showing whether less than 4 to 6 months, or 6 to 8 months, or 8 to 10 weeks, the important benefits are always there with the avelumab. So this is what is coming for the Asian patients, first line maintenance supportive. I don't think it is need to be discussed, because they are also doing, the Asian patients are also doing the same responses and same benefits as compared to the other ethnic groups. So whether you are in Asia or otherwise, you can always continue with this. This is what the summary of the Asian subgroup data, and they are also saying the same responses, no difference. Adverse events, like there has been 12% of discontinuation of avelumab due to the side effects. Death was attributed to the investigator to study treatment toxicity in 2 patients, 0.6%. That is, 1 death occurred due to the sepsis after 11 infusions of Bavencio, and the other due to ischemic stroke 100 days after the single dose of Bavencio. So they were not correlated with the use of Bavencio, but 2 patients they have lost. And this is immune-related adverse events. So no grade or 5 immune-related adverse events were occurred. High-dose corticosteroids, more than 40 milligram totally daily dose were administered following IO-related adverse event, and they were observed 1% of the patient who required high dose of steroids. So if the more than 12 months of treatment with Bavencio, only 1 patient had side effect, that is, patient died attributed to immune-mediated nephritis. This is as per the investigator. So continuation, what we were discussing, to how many months we need to continue the more than 6 months, 12 months, or 4 months. This is all coming here. Like this is what the trial. This is one is trial was showing that even if you continue with the 36 months, the response continues with the avelumab, but our patients can't afford more than 12 months, what we have in the practice or the ground realities. But the data showing that even the more than 24 months, the patient continues to respond. This is what the graph shows. And this is what the algorithm, which is showing how to go ahead with the subsequent lines. And even with the giving subsequent lines after Avelumab, this is, the NCCN guidelines showing a patient is ineligible to the cisplatin. Again, we have enfortumab vedotin and gem-carbo, or we have preferred regimen for the other dose dense MVEC, like in the second line setting. If patient is post checkpoint inhibitors, if a patient post platinum or other chemotherapy were given, you can use IO also, like Pembro and Nivolu, Avelumab. Like, so subsequent therapies are also being tried in many trials. This we have already discussed. So there are so many molecules are there in the second line. So this is the final impressive slide where they have shown that the maximum benefit or the survival was with the Avelumab maintenance, the 30 months. And apart from that, they're all, whether you give Pembro or Atezo or a combination of Atezo, Pembro, Durvalumab, the survival is less than 18 months. But this Javelin 100 is showing 30 months. So by all evidence, we can conclude that Avelumab maintenance is the best treatment standard of care today, which give the best of the overall survival, and having the least of the side effects and the toxicity. This I think we have already discussed. So thank you very much, everyone. If anything we can discuss around this, this is what they have given the doses. We know all 800 milligram infusion over 60 minutes every 2 weeks.
So can I say something?
Yeah, please.
So out of all the immunotherapy data in urothelial cancer,
yes.
So if you see, this is the most promising molecule.
Yes.
Because the best thing is obviously chemotherapy. So one must utilize the platinum doublet, preferably cisplatin. If eligible, go for carboplatin.
Definitely.
And only if they are carboplatin absolutely ineligible, as Dr. Ajay rightly said, then there is no need of doing PD-L1 unless and you just want to quantify, this is very high and then the probability just to encourage the patient, knowing the fact that very high score of PD-L1 gives good results, which is my own experience. I would not look at the data because I have actually seen it. Okay. So one should utilize these immunotherapy drugs not very actively, except this Avelumab, which is very, very fascinating data. And afterwards, we know after the first line chemotherapy, hardly any drug works.
Definitely.
I think this is the only space where no immunotherapy drug works and one must utilize.
Yeah. And like the science also says that the Avelumab matches with the mechanism of action of chemotherapy as well as the Avelumab, and it enhances the T cells activity, and not only the activity of T cells, but it preserves a lot of T cells, which on the long term gives immunity to the recurrence kind of thing. So this is what we this slide we skipped, but this is what the difference which makes between the other immunos as well as the Avelumab. So the scientific rationale, I will enlarge it, like activation of the primed T cell and reversion of the exhaustion. So the exhaustion of T cell is also prevented or reversed, and then it gives the innate effector functions potentiation, and it increases the tumor cell death and deepening of the tumor responses. So it is, I think, multifactorial as better than the combination. The most suitable combination with chemotherapy is Avelumab as compared to the all other IOs, as you said. So I think this ends. Dr. Ajay would like to say, Dr. Kaushal would like to give some concluding remarks.
Yeah, so in metastatic urothelial malignancy, if we treat only with the chemotherapy, then survival and PFS, they are the very short.
Yeah.
So with the available options of the avelumab, where the PR and CR is there, we can extend the life as well as the survival.
Yeah.
Without compromising the quality of the life. So it's a very wonderful drug, and if it's affordable by the patient, then definitely we can use it.
Definitely. Dr. Ajay, you like to say final comment?
So, sir, obviously, in bladder cancer, where is beyond immunotherapy, there is no second line treatment options available. And in second line, again, with immunotherapy, outcome is not so good. So maybe preferably we should try to push and wherever feasible to consider switching to avelumab maintenance.
I will share my experience of one patient that is little off Javelin, but that patient started with the GMCs, elderly patient suitable for cisplatin, and then somehow after completion of 5th cycle, he started having severe bleeding. We did cystoscopy, but nothing could be visualized because of all clots inside. So we gave supportive care, along with we discussed in the tumor board, and that radiation oncologist said, I will give radiotherapy to stop, or kind of palliative radiotherapy to stop the bleeding. So everybody agreed on that, and patient received radiotherapy for 10 fractions something, and then he stopped his bleeding hematuria, and then say after 4 weeks of that, we started avelumab, and touchwood is more than 1.5 years. He is keeping in CR. There is no disease. So I don't know whether the radiation added something to this, or definitely avelumab is doing so. This scenario, sometimes is tricky when you have a multidisciplinary and you can't stop the bleeding and or some kind of pain if it is. So if radiation oncologist comes into the picture, so I think we should add to that also. But Javelin doesn't say you either do cystectomy or kind of radiation. So that was very interesting case. We had it was 82 years old person, and surviving 1.5 months without recurrence in CR. So everything was given with and he was very adamant for cystectomy, because so much bleeding, we were all afraid whether it will be stopped or not. So better to remove the bladder also. So Nishanji, when we conclude the webinar today, I think the Pfizer people are also.
Hello. Yeah, sir.
Nishan.
Yeah, sir. Sir, I am 100% yes, sir.
Achha, you are awake.
Yeah, sir. Yeah.
Okay. So can we finish it off, or you have something to say? You want to reduce the cost of avelumab so that more patients can, because such a wonderful molecule, the company should do something for this.
Yeah, sir. Sir, I would like to tell you that the patient assistance program is there with avelumab, sir. Yeah, sir.
How is that?
Sir. So it is 1+2, sir. So every purchase of 1 vial, sir, the patient will get 2 vials free of cost, sir. So in every cycle, so patient, for every purchase of 1, he will get 2 free, sir.
Okay.
Yeah, sir. So if the patient dose is 600 mg, so in every cycle he has to purchase 1, or if the patient dose is 800, so it depends, sir.
Yes, that's great. So it is in spite of the patient is sponsored by ESI or CGHS, you will support, or you will not support to the sponsored patients? You support
no,
only
sir, for sponsored patient. Yeah, for the patient, those patients who are paying from their pocket, sir. For those kind of patients, sir, the company is ready to help them, sir.
Because otherwise the CGHS or ESI the organization is paying, so why too unnecessary, you know?
Yeah, sir. Yes, sir.
Because you are already giving, subsidized rates to these CGHS and ESI, you know?
Yeah, sir. Yes, sir.
Chalo, okay.
Yeah, sir. So thank you very much, sir.
so-
Shyam, sir. Yeah, sir. Please continue, sir.
No, thank you. We'll switch it off, and thank you very much. Personally, I would like to thank Dr. Bharat, Dr. Ajay, and Dr. Kaushal for such an enlightening discussion. And I will, have some time to meet physically. That would be fine. Thank you very much.
Yeah,
Thank you, sir. Thank you. It was very good moderation, sir.
Thank you very much. Thank you very much.
Hello.
So we'll leave.
Yeah, sir.
Okay. Bye, boy.
Yeah,
Good
sir.
night.
Good night, sir. Good night, sir.